Bayer for sponsoring this Little Lunch Talk. So Dr. Brophy is a Clinician Investigator at the Children's Hospital of Eastern Ontario Research Institute and an Assistant Professor in the Department of Pediatrics, Faculty of Medicine at the University of Ottawa. He's a specialist in the field of pediatric infectious disease, and his main research interest is in pediatric and neonatal HIV. He has several Canadian Institute of Health Research-funded multi-center studies across Canada, as well as a high HIV prevalence countries. He is the current chair of the Canadian Pediatrics AIDS Research Group and a Canadian Institute of Health Research. Canadian HIV Trial Network Investigator, and he's also the Pediatric HIV Clinical Advisor with the Clinic Health Access Initiative in Vietnam. So without further ado, please welcome Dr. Jason Brophy.
Thanks very much. And I'd also like to thank Bayer for sponsoring me to come talk to you today. I've been working with veterinarians here at Guelph for some time. Andrew Peregrine and I and Scott Weiss had worked on multiple applications to do some zoonotic infection research back when I was still a fellow in training at the Hospital for Sick Children in Toronto. And since then, we've continued to have some fruitful collaborations. And I was saying this morning that I think I might have potentially missed my calling. I find every time I come here, I'm like, this is so cool. And I was reminded this morning that I only have one animal. You have like at least 6 and many, many more species that you get to deal with every day. So I think veterinary medicine is fascinating. But my purpose for being here today is to talk to you a bit about the interface between human and animal medicine. We talk about this concept of One Health, which I'm sure all of you hear a lot more about than we do in human medicine. But I think it's an excellent concept for thinking about how we need to address public health issues in general, not just by species. And so my title for my talk today is Vets and Physicians Working Together to Reduce Zoonotic Disease Risk. And what I wanted to do during this talk is to help us understand a few of the high-risk humans and high-risk pets with respect to zoonotic infection risk. Discuss some common zoonotic infection case scenarios. So I'll share with you 5 or 6 cases. I don't know if veterinary medicine is the same, but in human medicine, when we give talks, if it's just a bunch of didactic slides, it gets a little boring. But when you talk about cases, it's often a lot more interesting, and people tend to remember that better. I want to have a specific focus on bites and bite prevention, because I think this is one of the most common things we see in human medicine that is relevant to you guys, and also introduce a few resources on this topic. I'm a reasonably informal speaker, so if anyone has any questions or if I'm saying something that isn't vet speak or it's too human medicine speak, stop me and tell me. I'd rather clarify than have you not understand. So we'll start off with a case. And this is a patient that I actually saw. A 5-year-old girl with leukemia, and the leukemia was recently diagnosed in the past year. She was admitted to hospital with abdominal pain, diarrhea, and fever, and she had received chemotherapy 8 days before. The parents were told that she would become neutropenic, and that's common with chemotherapy. Is usually about 1 to 2 weeks after chemotherapy, the person's neutrophils and platelets and hemoglobin will begin to drop. And they were told to watch closely for fever, because that would be a high-risk time when she was neutropenic. On admission, she had no ill contacts that she volunteered, or the family volunteered, and no possible contaminated food ingestions. When they examined her, she was febrile, tachycardic, normal blood pressure, respiratory rate, and oxygen saturation, but really had a very tender belly on exam, and had blood and urine cultures taken, as well as stool for bacterial and viral cultures, and Clostridium difficile testing. So patients like this are in the hospital a lot. They receive a lot of antibiotics. They're at risk for Clostridium difficile infection and the colitis that kind of accompany that. So she was admitted to hospital as a case of febrile neutropenia and started on broad spectrum IV antibiotics, including antibiotics the antibiotic metronidazole to cover Clostridium difficile infection. And after 48 hours, she had improved on those antibiotics with respect to her fever and her diarrhea. But her blood cultures and stool cultures both grew Salmonella enterica. And so the oncologist and the infectious disease service, we both re-questioned the family and learned that there was a new family pet named Gary, who was a turtle. And so the story was that the child's older sister had acquired a turtle 2 months previously. And the family recalled having been advised not to acquire any new pets after their daughter's diagnosis, but things don't always go as recommended. And they thought that they had adequately protected their ill child with leukemia by restricting her contact with the turtle. They kept the turtle only in the sister's room, and the girl with leukemia was not allowed to touch the animal. But the sister had developed a mild diarrheal illness 2 weeks after getting the turtle, and the family cleaned the turtle's tank in the bathtub that the child was bathed in, and both girls were regularly bathed together in the same bathtub. And so really the take-home lessons from this kind of case, and this is not an uncommon case at all, this is a case where something bad happened, but there are lots and lots of near misses where you ask questions, you learn stuff going on at home that's probably not a good idea, and you can thankfully get to address it earlier. But what we learn from this kind of case is that counseling isn't always effective. And in this case, the parents either didn't recall to the advice or they didn't adhere to the advice they were given. Because in our practice, when oncologists make a diagnosis of leukemia or other malignancy and the patient's going to be immune suppressed, they're usually counseled not to get rid of pets, we're not cruel, but they're advised not to get new pets if they can avoid it, and to avoid high-risk pets if they're going to get a new pet. So avoiding juvenile animals, avoiding things like reptiles. And so that's advice that we try to give out. Secondly, the family didn't volunteer the information about the new pet at the time of admission, leading to a delayed diagnosis. So this suggests that the family didn't appreciate that this was a risk that they had introduced by acquiring this new pet. And so it reinforces for us on the medical end that we really need to ask a good animal contact history. So I always do that because I'm the infectious disease doctor. And I'm interested in it, obviously, because I'm here today talking to you. But not everyone knows what a good animal contact history means and what would be high-risk practices that we should be looking for. And finally, another really good take-home lesson is that despite no direct contact with the pet, the risk of disease transmission was still there, especially for a high-risk individual like this patient. So first, there could easily be contaminated hands after dealing with the turtle or dealing with stool from the older sister, and those contaminated hands could lead to contaminating the ill child during food preparation or routine childcare. There's definitely a potential for contamination of shared space in the bathtub by washing the animal's habitat in that space. And finally, there's close contact with the sister by sharing a bathtub, and she may well have been asymptomatically shedding salmonella in her stool because it hadn't been diagnosed and identified as part of the girl's initial illness. So I think this is a good case that kind of reinforces how we really need to be vigilant about these kinds of risks. So when we talk about zoonotic infection, it's defined as the transmission of infection between animals, and sometimes it's narrowed in specifically to vertebrate animals, to humans. And there are a vast assortment of potential pathogens and animal associations. And this really is an important issue. A paper in 2001 suggested that of the over 1,400 known species of infectious agents, viruses, parasites, bacteria included, that are known to cause disease in humans, 61% were zoonotic. And when you think about emerging infections globally, most of the time, these are zoonotic diseases. And we only have to look back at the last 10 or 15 years to see that. SARS is a zoonotic infection. H1N1 and H5N1, hantavirus, MERS-CoV. And the list will continue to go on. And as you go out into your practice, we're going to learn more and more about additional new infections. While wild animals are a major source with respect to these emerging diseases, and domestic animals as well, pets remain an important vector or potential reservoir of disease. Here in Canada, over 50% of families own a pet. 1/3 have one or more cats, 1/3 have one or more dogs. And so this is an important risk factor for infection in those households. And often infections are acquired from animals are due to their own normal flora. So I usually ask when I'm taking a zoonotic disease history, do you have a pet? Is it old or is it a new pet? Is it a pet that's a juvenile under 6 to 12 months? And is the pet ill in any way? Did they have diarrhea or skin infections, stuff like that? But it's important to recognize that often these infections aren't causing a problem in the animal. It's their own normal flora in the mouth, in the GI tract, and so we need to be vigilant that even a well pet can still have the potential to transmit a pathogen. So in addition to routine or standard pets, the rate of non-traditional pet ownership has increased in recent years. And that brings with it the potential for new exposures to novel or less common pathogens. When we talk about non-traditional pets, these are defined as imported or non-native species, or species that originally were non-native but are now bred here in North America. It also includes indigenous wildlife, so keeping a raccoon or a coy dog, like a coyote dog hybrid. And these kinds of animals, because some of them are new and weren't traditionally pets, we may not recognize the zoonotic disease risk, at least in the human medicine realm. Probably in the veterinary realm, it's better known. But things like hedgehogs carry a risk for salmonella, pigs carry a risk for strep suis, the list goes on. And so this is a list of all the different non-traditional pets that we recognize, and there certainly seems to be an uptick in the level of reptile ownership. And when I was in medical school, this was not something we talked about, and it wasn't something that my friends had a lot of, but certainly in recent years, it seems as though reptiles and amphibians in particular, there seems to be a lot more ownership as pets. And so non-traditional pets pose a potential risk of both infection and injury. Sometimes they're caught in the wild and rather than bred in captivity, and so you know better than me that wild animals are less predictable than domesticated animals. With regards to unpredictable behavior, and also increased risk of having potential pathogens they acquired in the wild. Among non-traditional pets, like the case demonstrated, reptiles pose a particular risk because of the high carriage rates of Salmonella species, which are intermittently shed in their stool. We do have guidelines for the prevention of zoonotic infection on the human end, and I'm sure that you share with your families and their pets who have pets certain zoonotic infection prevention guidelines. Hand washing is really key, and for younger children, less than 5 years, that hand washing should be supervised. We don't trust children to wash their hands properly at that age. Not keeping animals or letting animals be where food or drinks are prepared or consumed. Maintaining a healthy animal, making sure they're having regular follow-up with you guys to ensure that they're healthy. Proper cleaning and disinfecting after an animal in the environment. So scoop and poop, poop, stoop and scoop and poop. And I think, I don't know about the rest of you, when I was a kid, I don't think I ever saw anyone pick up any poop of an animal. I grew up in the country, mind you, but nowadays it's pretty common practice. And then high-risk individuals should not handle high-risk animals. And these include, again, reptiles and amphibians, but also rodents, ferrets, baby poultry, or animal-derived pet treats. And although we like to kiss our pets, we probably shouldn't. At least not on the mouth. And so I've talked a lot about stuff that you know already, but from my end, what humans are considered high risk for zoonotic disease? When we look at the literature, there are a few key groups that we identify as high risk for zoonotic infection. The extremes of age are the most common. So children less than 5, especially infants and newborn, infants less than a year and newborns especially. And elderly over 65 years of age. We also worry about immune-compromised patients, and the range of immunocompromised nowadays is very broad and increasingly broader as we have more and more types of immune suppressants, many of them specific for certain diseases, and really it's hard for us to keep up and understand what do these different immune suppressants convey in terms of zoonotic disease risk or risk of infection in general. I'll give you one example of that. With the tumor necrosis factor antagonists, TNF antagonists, like infliximab or Remicade is the first one. These are very commonly used immune suppressants for common conditions like rheumatoid arthritis and inflammatory bowel disease, Crohn's or colitis. And they carry with them a specific increased risk for both mycobacterial diseases like tuberculosis, but also the Mycobacterium marinum, which can be associated with aquaria and contact with water-dwelling animals, and also for fungal diseases like histoplasma and blastomyces. So these are things that obviously will have some relevance to you guys. And finally, the other high-risk group that we talk about is pregnant women. So I'll come back and give you a few more cases, because I think the cases make the point better than me talking. So the second case, a 10-year-old boy, previously well, referred to my clinic with a history of fever, arthralgia, and rash for 3 weeks. The fever initially was just for the first few days up to 39 degrees, and then on the third day, he also developed a rash, which was quite diffuse, including his palms and soles. And in humans, that carries with it a certain categories of diseases that you don't count if it's not on the palms and soles. He also started to complain of right shoulder pain, but there was no swelling or limitation of in the range of motion of his shoulder. On the 5th day of fever, his joint pains migrated to his left shoulder and his right ankle, and his right ankle was red, hot, and swollen. He was seen by his family doctor, who sent blood work, which showed a normal CBC but high inflammatory markers. They also did some screening tests for rheumatologic diseases because of his joint complaints, with an ANA for lupus and a rheumatoid factor for rheumatoid arthritis. At that point, these investigations were somewhat reassuring. His rash began to resolve, and his joint pains persisted, but then he also developed migratory bilateral knee pain, and then his left elbow and his left wrist. By the 14th day, the fever and rash were gone, but his joint pains were persisting. On the 23rd day of his illness, his fever came back again, and his left ankle became red, warm, and swollen, and he was unable to bear weight. After that, the mother took the child back to see the family doctor, and mom requested to be sent to the infectious disease clinic after an internet diagnosis suggested, an internet search suggested the diagnosis. Usually we cringe when we see those kinds of referrals in our mailbox, because there's lots of stuff on the internet that you may or may not want to trust. So when he came to my clinic, he was not unwell, but he was still febrile. He had a flow murmur, grade 2 to 3 out of 6 systolic ejection murmur over the left lateral sternal border. He had no hepatosplenomegaly. He had some rash, red maculopapules on the upper and lower extremities, his belly and his buttocks. He had one painful red nodule on his left palm, and he had a minimally swollen left ankle. So, can anyone guess what she Googled? It's a zoonotic infection talk, so there's a pet involved. So the history revealed that the family had recently acquired 3 pet rats, one for each of the 3 children in the family, and the patient's rat was definitely the most affectionate. He enjoyed climbing on his shoulders, scratching his neck. He never bit him, but he licked his neck a lot. He's very affectionate. And so the mother searched for rat and fever and arthritis, and Google told her that this could be rat bite fever. And if you look at the symptoms of rat bite fever, they matched this child's symptoms exactly. So the family doctor hadn't heard of rat bite fever, but the mother found it. And so rat bite fever can be caused by 2 different kinds of bacteria, Streptobacillus moniliformis or Spirillum minus. And in humans, it's characterized with an abrupt onset of fever, chills, muscle pain, vomiting, and headache. A maculopapular or petechial rash follows, predominantly on the extremities, including the soles and palms. A non-suppurative migratory polyarthritis or arthralgia follows in 50% of cases, and it has a relapsing course up and down over approximately 3 weeks. So this child practically read the book in terms of the symptoms that he presented with. And so we empirically started him on treatment with ampicillin and penicillin and gentamicin, and he promptly improved. It's a very difficult pathogen to identify. We tried to culture his blood in multiple different ways to confirm the diagnosis, and we weren't able to confirm it in this case. I saw this patient probably 7 or 8 years ago, and we had another patient probably a year or 2 ago that had the exact same story, and we were able to culture the Streptobacillus moniliformis from both his blood and from a pustule on his palm, or I'm not sure exactly where it was, but we aspirated a pustule on his palm and grew the bacteria. And so you've heard about the 2 cases I've seen now. So it's not very common, but it's definitely a classic presentation. The next case is a 12-year-old girl with spina bifida, and she had a Mitrophanoff procedure for neurogenic bladder. Does this exist in the animal world? I don't know. So Mitrophanoff procedure is where they take a piece of the small bowel and they use it to augment the neurogenic bladder. So the neurogenic bladder doesn't squeeze the urine properly, so it sits there, and they often will they have a high risk for urinary tract infections. And so the Mitrophanoff, basically they rebuild the bladder using small bowel, and they also take the appendix and bring it out to the surface through the umbilicus. As someone who doesn't like belly buttons, I really, really don't like seeing these patients. They're very nice, but it's not my thing. And basically they catheterize themselves through this appendix origin conduit to the bladder several times a day. Works very well for them. So this 12-year-old girl had this procedure, and she presented with fever, nausea, vomiting, and a change in her urine in that it was more foul and more mucousy. People who have Mitrophanoffs have very mucousy urine because it's from the bowel, and bowel makes mucus. A urinalysis was done when she came to hospital. It showed nitrites and leukocytes, so suggestive of a urinary tract infection. And so she was admitted to hospital because she had fever and also because she was a complicated patient with an abnormal urinary tract, and empirically started on ampicillin and gentamicin. So the following day, her urine culture result showed possible Capnocytophaga species. And usually this is associated with dog bites. So this is the point where the pediatrician usually calls and says, "I've never heard of this bacteria. Can you come see this patient?" And I said, "I know that bacteria." And so they went back to the patient to ask if there was any contact with dogs, and the patient admitted to having a dog and to letting it lick her Mitrophanoff site. Yes, all of your faces are exactly what my face did when I heard that, because I don't like belly buttons. And so the next day, the lab actually confirmed that the pathogen wasn't Capnocytophaga, it was Pasteurella, which is usually associated with cat mouths and cat bites, but can also be found in the mouths of dogs and many other animal species. So this patient recovered, and she received a terse lecture from me on proper care of her Mitrophanoff. Oh, yeah. Okay, next case. So a mother took her 4-month-old shopping and returned home and was removing the groceries from her car while the child was still in the car seat in the back of the car. Mom took some bags of groceries into the house, and we came back out and found the child crying and found a feral cat that had been hanging around their house, exiting the car very, very quickly. The child was found to have scratches at the base of her 3rd digit with a puncture wound in the distal phalanx. This is not the cat, but I thought she was represented. So the child was taken to the family doctor, and she was given a tetanus shot. The wound was cleansed, and she started empirically on clavulin. And I have to give it up to this family doctor that that's exactly the right management, and they did the right thing. And I'll tell you a bit more about empiric management of bites a little later. The cat, unfortunately, I asked, what happened to the cat? I was thinking we need to test the cat for rabies, because that's kind of an odd thing to do for a cat to attack a child who didn't provoke it. I was told that the cat had met his maker, and the body, and I said, they said, but the public health people came and collected the body and took the brain and examined it, and it was negative for rabies. So this does not usually happen. I do not endorse this. I do endorse looking for rabies, but this family took it into their own hands. But fortunately for the child, it turned out that there was no rabies risk. The child did develop fever, though, and was irritable and had diarrhea, which was attributed to the antibiotics. And the finger actually became swollen and started oozing green-yellow discharge. She completed a 2-week course of clavulin, but the finger was still swollen and red. And so the antibiotics were continued by the family doctor, and they were referred to my clinic. And when I saw her, the finger was still quite a bit swollen and a bit red, but the child was otherwise well. So I sent her for an X-ray, and it basically showed a mixed lytic process involving the middle phalanx of the right third digit. So this is normal bone, and this is bone that has a lytic process going on. And this is another view, and another view, and you can see there's almost even some displacement. And so I admitted her at that point as a probable osteomyelitis or bone infection secondary to a cat bite. I had my plastic surgery colleagues see her, and they felt that the X-ray appearance was consistent with both infection, but also a displaced fracture of the middle phalanx. And so this child ended up getting IV therapy for 1 week, and then another 11 weeks of oral clavulin thereafter, because we treat subacute bone infections and acute and chronic bone infections much longer than we would treat an acute bone infection. And because this had gone on for a while, I thought it was necessary. So at this point, I'll turn to bites. They're really a major infectious risk with pets. In terms of the number of bites per number of pets per number of families, I can't say that this is a major public health risk, but it's something that requires individualized advice to prevent. It's a common entity. 4 million bites per year in the US, 800,000 medical visits per year, which accounts for up to 1% of ER visits. Most of these are dog bites, about 80% in most reviews, followed by cat bites, and that third pesky animal, humans. And they each have a certain set of characteristics that are important for us to recognize because they carry with them different risks for complications. Dog bites are usually amongst young people. The majority are under 20 years old, and majority are males. Children are more likely to sustain bites on the face, head, or neck, and as a result of that are more likely to die of the attack. This is rare, but certainly happens. And the reason for them having more head and neck bites is because of their size. So if you have a German Shepherd who's this tall and a child who's this tall, then the neck is exactly in the right line of fire. In general, bites are more commonly involve the upper extremities, though, and then the lower extremities, face and trunk. And because dogs have more grinding teeth and larger teeth, they more commonly cause crushing injuries and lacerations. This is in contrast to cats, who tend to, because their teeth are long and slender, they tend to bite through. Sadly, some stereotypes have basis in truth. So young middle-aged women are the most common victims of cat bites. All those lonely nights at home on Friday night. And cat bites tend to occur more commonly on the hands because you can think, oh, nice cat, nice cat, nice cat, devil cat. And then followed by arms, lower extremities, face, and trunk. And like I said, they more commonly, because the nature of their teeth that are longer and more slender and pointy, they tend to cause more puncture wounds and scratch wounds. And this carries with it a greater risk of invasion into the bone, like with this child, And so what can seem to be a reasonably minor cat bite, because it's a very small entry point, can actually go very deep and cause a lot more problems. If it penetrates the bone or penetrates the joint, then it's much more likely to cause a more substantial infection that needs more aggressive treatment. So this is a pictorial showing where the most common areas for dog bites and cat bites. And you can see that the majority of both occur on the hands. And that's like, nice dog, not nice dog. And then human bites, the third dangerous animal. These are typically fight bites. And that's where this kind of thing happens. The guy didn't mean to bite him, but his teeth kind of got in the way of his fist. And so the puncher is the one who sustains the bite wound to his hand. I say he because if we're going to talk about stereotypes, then it's mostly men. And these have a higher likelihood of delayed presentation, subsequent infection, and potential for joint involvement, because let's throw out the other stereotype. It's usually when they're drunk, and so they don't recognize that it's a big problem until the next morning. And so with respect to the risk of bite wound infections, dog and human bites are lower risk in terms of about 10 to 15% risk of infection overall, but cat bites have an up to 50% risk of infection, with complications including abscesses, bone joint involvement like I talked about already, sepsis, endocarditis, meningitis, and brain abscess. In terms of high-risk patients, we think about risk in three ways: high-risk patients, high-risk interactions like bites, and then high-risk situations. And so the high-risk patients are, again, the older and younger, so over 50 for bites and less than 2 years, immunosuppressed. Asplenics are known to have a specific risk for capnocytophaga infection. Alcoholism and chronic liver disease, diabetes mellitus, vascular disease, pre-existing edema, and prosthetic and joint valves or joints. There are high-risk bites, so again, talking about puncture wounds and cat bites, crush injuries with devitalized tissue, bone and joint proximity, hand, foot, face, and genital wounds, and primarily closed wounds. So if they come to the emerge and they have their wound closed right away, then that sometimes can carry a higher risk for infection. And then high-risk situations, such as delayed treatment. So I'm going to share this case isn't nearly as funny as the rest, but this one we just saw in the last year, and it was probably the worst one that I've ever seen. A 23-day-old infant. The family was planning an outing and had the baby in the car seat ready to go out, and one of the parents went back to collect something in the house, and they came back in the room, and the family dog, who's a husky, had attacked the baby and bitten them on the head. And there's obvious brain tissue. The baby was bleeding severely. The ear was torn off, and there was a mandibular laceration. So the dog bit like this. And so they called the ambulance. They brought the baby to the hospital. The baby was basically dying of hemorrhagic shock. And so they took her immediately to the operating room, and they managed to save her. And she was left with some damage. This was the CT and MRI, and so you can see like a significant portion of the brain had to be removed or was removed. And so luckily this baby survived and has gone on to do quite well with some neurologic sequelae. But I think it's a very good point to drive home the fact that even the most docile animal, and this family said that their dog was very, very well behaved, is still an animal and still can have unpredictable behavior. And so we need to be cautious with respect to how we manage and mitigate risks in association with higher risk patients or people. And I put that case in this point because I actually contacted Scott Weiss and Andrew Peregrine here to ask their help, because I knew from my interactions with you guys that staph pseudointermedius is one of the pathogens that can be seen in animal bites and animal mouths. And in our human labs, that is a pathogen that would not be picked out as pathogenic. It would be seen as a coagulase negative staph, species, and we wouldn't really appreciate it as a potential pathogen, and it can be quite resistant and not respond to antibiotics. So this child, I was involved because we always get involved with any open brain injury because it will need prophylactic antibiotics. The evidence isn't great for that, but we do it because we don't want to have a trial to look and see if we're right or not. And so I swabbed this animal's mouth and sent it here to see if there was any carriage of staph pseudointermedius or MRSA or other pathogens. But in general, bite microbiology reflects two things: the oral flora of the animal and the skin flora of around the bite. And so in that way, it's often a polymicrobial infection. We talked already about Pasteurella species being the most common bacteria for both cat and dog bites. Capnocytophaga is more associated with dogs. But we can also see strep and staph pseudointermedius, anaerobes, which are very common in the mouth. And then Eikenella corrodens is kind of the human equivalent of Capnocytophaga, in that it's something that's usually in human mouths that can cause infection. And then there are special situations, and so this isn't the standard, but different strange animals and interactions with strange animals can have been associated with more unusual pathogens. So there have been cases of blastomyces or blastomycosis, which is an environmental fungus common here in Ontario and in other parts of North America, associated with dog bites. And this is usually a soil pathogen, so you can imagine the dogs rooting around in the soil and then bite somebody with the soil in their mouth, and they're introducing this fungal infection, which wouldn't be your typical bite pathogen. We think about tularemia, erysipelathrix, which is a fish pathogen, and Bartonella in association with cat bites. Streptobacillus moniliformis, like we already mentioned, with cat and sometimes rat and sometimes cat bites, so cats eat rats. So, Pseudomonas, Aeromonas, and Vibrio are associated with marine bites, marine species like sharks, but we also see it with fish. One of the questions on my infectious disease exam was of someone who was fishing in Northern Ontario and got bitten by a pike, because they have really sharp, long teeth, and then got an infection with erysipelathrix. That was a tricky one. Actinobacillus in horse and sheep bites. Herpes B virus infection, which can cause encephalitis, is associated with certain types of monkeys, including the cynomolgus macaques. Eikenella and hepatitis B and potentially HIV with human bites. And then seal finger. I did my training in Newfoundland, and so seal finger was something I learned about there, and I don't think I've ever heard anyone talk about since. And it's thought to potentially be due to mycoplasma bacteria, and it's associated with seal and fox bites or exposures. So people who butcher seals or butcher foxes. There are a lot of things to know about bite wound management, and that isn't work that you'll be doing, but the take-home point I would like you to share, because sometimes people will come to you with these kinds of complaints, I know because I've heard from other vets, is that really the basic advice should be always to clean the wound right away. Think about prophylactic antibiotics, especially for cat bites or more severe bites or bites with devitalized tissue, and to pay close attention to these bites. Moving on from bites, there are other specific risks and emerging problems that we hear a lot about nowadays. Salmonella is one of the big ones. So that was the first case. There have been many outbreaks in North America in recent years, many in association with animals or animal-derived foods like poultry, beef, eggs, and dairy. And there are specific animals that have been implicated with these salmonella outbreaks. In particular, poultry like baby chicks, livestock, reptiles, amphibians, and rodents. And so if you Google or do a PubMed search about salmonella outbreaks, you see there's like lots and lots of them now. Local research here in Ontario has shown that dogs have a high rate of salmonella carriage. About a quarter of all dogs and a quarter of all households with a dog were found to be shedding it. And so this can be a problem. And it's been significantly associated with eating a raw food diet, especially raw eggs and raw meat, and having more than one dog in the household. So one more case, a 48-year-old man with type 2 diabetes. I didn't see this one was published. I don't do adults. A 48-year-old man with diabetes and chronic renal failure who's hospitalized with a right leg amputation wound infection 2 months post-op. And the culture grew MRSA, and he was treated, and he also had a nasal swab at the same time that was also positive for MRSA. So that suggests that not only did he have a current infection with MRSA, but he's also colonized with it, which is probably why he got the infection in the first place. So the wound was treated with vancomycin for 10 days, and he also had a decolonization approach where he had chlorhexidine baths once a day, and he applied intranasal mupirocin. But the wound infection resolved, but the nasal culture remained positive for MRSA for some time. And so they tried again to eradicate it, and they still couldn't eradicate it. His wife, who also had health problems, a kidney transplant, and type 2 diabetes, then developed cellulitis herself with MRSA. And she had a negative nasal culture. And so the doctors were stumped. They tried again and again to decolonize this family because they're getting repeated and serious infections, and they weren't being successful. Usually we can eradicate. So they decided to get a nasal swab from the only other member of the household, who's a Dalmatian, and the culture revealed MRSA with the same susceptibility pattern as the humans. And they also found that it was resistant to mupirocin, which we don't usually test for. And so further history revealed that the dog routinely slept with the humans and licked their faces. And so they prescribed vancomycin ointment to all the household members, including the dog, and finally led to eradication. So MRSA in pets is increasingly being recognized as a problem, including numerous Canadian reports, and you guys here in Guelph are amongst the leaders in terms of reporting this. And so it's been associated with, there's an association of risk to transmission to humans with horses, pigs, dogs, cats, and dolphins. And one recent US and Canadian study showed that 27% of households where an animal had a previous MRSA infection also found a human colonized with MRSA. And so this is an issue in terms of trading pathogens back and forth within households. There are many other scenarios where we think about pathogens and specific pets and risk of infection for humans. Dogs and cats can carry human pathogenic Giardia and Clostridium difficile. In Ontario and Quebec, 2 to 14% of dogs and 5 to 12% of cats carry Toxocara canis or cat eye in their stool. Barnyard animals can carry a variety of pathogens. Here in Ontario, we're acutely aware of the risk of cattle carriage of E. coli 157 due to the Walkerton disaster some years ago. But also with cattle, we think about Cryptosporidium and Salmonella. And rodents can have Salmonella and also lymphochoriomeningitis virus, which can lead to congenital infection in babies or meningitis in babies and adults. And so what can vets do? So the title of this talk was, how can we work together, or how can we complement one another? And so from my perspective, I think it's important for you guys, when you see families, I'm not sure how palatable it is to ask about the health of human household members, but I think it's reasonable to ask about high-risk household members. If there are young children or elderly, particularly compromised elderly patients, immune-compromised people who've had bone marrow transplants or solid organ transplants, and also pregnancy. Pregnancy is a time-limited kind of condition, but important to know about when it happens. And also to ask about high-risk pets. Ask these questions in relation to high-risk pets. So if someone's coming to you with their sick turtle or their sick rodent, maybe ask, is there anyone in the household that you would be worried about having exposure to these patients, to this pet? And when you find out about these high-risk household members, or even not, because sometimes when you meet them originally, there's no high-risk person, but someone in the household becomes high-risk. They become immune-compromised due to the diagnosis of a new condition, or there's a new baby that arrives in the family. So providing resources on good animal husbandry to reduce risk, for example, avoiding raw food diets, co-sleeping, proper waste disposal, proper cage or other habitat cleaning, I think is really important. And when the animal is ill with something that can affect humans, advise on infection control practices in the household. I think it's important to provide balanced advice, though, to balance the risks against the benefits, and avoid heavy-handed messaging due to overreaction. So, like in one of my cases, the family went out and killed the cat. It was a feral cat, and probably that's what would have happened anyway if they called animal control. But I've also seen it where I'm just asking questions about the potential for zoonotic infection in someone with an undiagnosed infection. And the next day I'll go back and the family will say, I got rid of the cat. And I'm like, no, I didn't say to get rid of the cat. And so I think it's important to avoid heavy-handed messaging and make sure that they know if there is a potential for infection, it's not the animal's fault. It's something that they're colonized with, for example, with respect to salmonella and reptiles. And the best way to approach that is just to be careful and know what to avoid doing, not to get rid of the animal. It's also good to use reasonable measures to reduce household risks. So avoid high-risk interactions, like don't let a dog lick your Mitrophanoff or lick your central venous line. Dogs do that. I mean, they're often mucky, those areas, and animals tend to, you can tell me if I'm wrong, but they tend to go for the smelly things, and they like licking and rooting around in it. And so it's important to avoid those high-risk interactions, especially with high-risk humans, and address any dangerous practices quickly. I always try to share with people that I think the pets are worth any risk that is there, the majority of them, like notwithstanding 300-pound boa constrictors in the house or crazy stuff like that. But on average, the average pet is worth more in terms of good health outcomes than bad health outcomes. And it's commonly known that, well, amongst people who like pets, that there are lots of proposed benefits of pet ownership. Companionship is greatest amongst pet owners, decreases in isolation, particularly for people with mental health problems, increased sense of social support, and also increased activity amongst pet owners, and we all need more exercise. Likewise, advice to remove a pet from the home from high-risk patients may well worsen their quality of life. And so you can imagine a child diagnosed with leukemia then is told you have to get rid of your cat. Like that's not okay. And so I think we can all work together to advise people on how to reduce the risks rather than reduce the pet contact. In terms of guidelines for immunocompromised patients in particular, there's few prescriptive guidelines in existence. General advice, like I said, is not to get a new pet after diagnosis, and if they are getting a new pet, to avoid higher risk pets like young ones, puppies and kittens, as they are higher risk in terms of their behavior and the pathogens they carry, and also to avoid high-strung breeds of dogs. Ensure the pet is examined by one of you guys and their vaccinations are up to date, and to seek a pet's advice regarding risks. And there really are lots of resources. I frequently refer people to the Worms and Germs blog from here at Guelph, because I think it has a lot of excellent information and a lot of really niche information that's hard to find. The other one is the CDC website. So this is the Worms and Germs blog, which I'm sure most of you know already. And then the CDC website has this healthy pets, healthy people section, and they have a pet prescription where it has, you can actually provide a prescription for what kinds of precautions should be taken for different types of pets. So in summary, I think pets are potential sick contacts for humans presenting with infections. And it's important that we're aware of the risks with specific animals and attuned to the potential contribution of animal contacts to specific situations, like immunocompromised patients. Likewise, though, pets are a source of enjoyment for most people, and careful attention to pet health maintenance, husbandry, and observation is key and can help avoid most of the potential downsides. And veterinarians should be considered a resource to human medical practitioners and vice versa. I reach out to Andrew and Scott on a regular basis, and they do the same with me. And I think that's the way we should be having these kinds of discussions. I don't know anyone who wouldn't be open to that. And I think we just need to make it known that we are interested in talking to one another. And that's it. And I'm happy to take any questions.
Why was it so difficult to culture the rat bite fever bacteria?
It's just a very fastidious organism. It has certain nutritional requirements that aren't routine in the lab. Like when we're trying to grow regular bacteria, this one is more difficult to grow, and so it required a lot of extra massaging and adding additional nutritional supplements to the culture media. Thanks.
How do you suggest that veterinarians, vet students, or any people working with animals approach their doctor when they think their symptoms might be due to a zoonotic disease? Because I've heard a few cases of fellow colleagues have gone to the doctor and they seem to disregard what they're telling them about what they think the symptoms are and kind of focus on something else.
Yeah, no, that's a very good question. Sometimes the patient is better informed than the physician, and so that's not an uncommon thing. I think first I would maybe come equipped, so bring something you read, because a lot of people, they don't know what they don't know in terms of human physicians, and so that's one way to say, actually, I think I'm legit. I think what I have is a genuine concern. Ask for cultures. So if there are tests that should be done, many people use an empiric approach. Like you say you have a cellulitis, they give you the cellulitis treatment. They don't do the swab to try and confirm what it is. And so that's another way, because if we can identify a zoonotic pathogen, then that's going to make the diagnosis more readily than doing it from a syndromic approach. The other thing I would say is try to find people who have an interest. So if you came to me with that, I'd be like all over it, because I'm interested in this, and I think that I have probably a greater than average knowledge in terms of zoonotic infections. And so finding physicians who have the same types of interests and the same types of bent in terms of how they would work something up is a good thing. You never know who you're going to get in the emerge, but I think just like I know a few vets in my community in Ottawa who are interested in this kind of stuff, and I could call on if I wanted to get the pet in the household tested. You could find human physicians in your community that are going to have the same kind of interest and increased knowledge. Okay, thanks. Yep.
I'm wondering if zoonoses secondary to stings are on your radar at all. I work with honeybees, and a couple of weeks ago I got stung on both hands. One of them I washed under warm water for a few minutes because it was very painful. I probably got more poison in that one hand. But over the next 30 hours, the swelling went all the way up my arm. And I live with a vet, and various people sort of think your arm is like purple. It's like really like blue and not looking really good. It looks like it might be cellulitis. So I went to a walk-in clinic. The doctor said, yeah, it kind of looks like cellulitis. Gave me antibiotics, right? Within hours, it began to go down and start progressing over time, and sort of marking off the progression of this chronic.
Yeah, that's a very common issue of insect bites or stings in general, and having these rapid inflammatory responses. And most of the time when I hear about something like that, when the emerge physician calls me, things tend to be less likely to progress that quickly with an infection compared to an allergic reaction or like a otherwise kind of contact reaction to bites or stings. And so I'd be more inclined to lean on the non-infectious side, but most of the time we try to be cautious and treat anyway, because we don't want to be wrong. And something that progresses very quickly like that needs to be monitored very closely. Yeah. So we often never get a clear idea, but thanks.
Awesome. So thank you, Dr. Brophy, for coming again today. And thank
you very much.
I think it's very nice to sponsor this talk. If you know anyone who's interested in the talk but didn't have a chance to come see, there will be a video available later. There's another link.
Oh, I also forgot to mention, during one of the projects that I worked on together with Scott Weiss, Andrew, and Jason Stull, who is a PhD student here, we developed a lot of information materials for handouts to people about what are the risks with certain animals and what are higher risk versus lower risk pets. Those are all available on, I think, the Worms and Germs website, but the ones that we developed specifically for our study, Andrew has at his disposal and can distribute them. And there's also a list of instructions for immunocompromised patients about summarizing the types of information that I've shared with you today. So that information is there. And then I held this up but didn't explain it. This is an article that Jason Stahl, Jason Brophy, and Scott Weiss, the three of us wrote for the CMAJ, which is an exceedingly difficult journal to get published in. So I was very happy. And it's called Pets and Pathogens, Who's at Most Risk. And so this is kind of summarizing what I've talked for the human provider, but a lot of the information is equally of interest to you. Thanks.